So going along with what Dr. Sclavasi talked about earlier, I made a few notes, a few things came to mind in addition to what I prepared. I don't know anything different because where I trained, we monitored many, many cases. And so it's something that I was used to doing when I got done with my training because of where I trained. Not everybody monitors as much as we did in Pittsburgh. And it was very useful for us because by the time I got to Pittsburgh in 1992, they'd already worked out a lot of the technology and the techniques. So, so just a little history in Pittsburgh. I wanted to go through the history of Yuri becoming acquainted with us. So in 1997, one of our residents, Dr. Mark McLaughlin, came here for three months, I believe, and worked with Dr. Shulev. And Mark sought out Dr. Shulev to try to find somebody he could come work with and see how a different system of healthcare was delivered. And when Mark came back, he brought Dr. Shulev to one of our meetings. I mentioned 1998. Dr. Janetta came shortly thereafter for the first time to your hospital here. And then in 1998, I was told was your first microvascular decompression. Was that first spasm or facial pain? Your first case?
Microvascular decompression.
Okay.
It's a trigeminal oral.
Oh, trigeminal. Yeah. And then I met Dr. Shulev I still remember the restaurant. We ate at a nice steak restaurant.
I remember just the restaurant.
I remember the restaurant. It was very nice to meet Dr. Shulev and hear about how things are done in Russia, and it's always interested me. So there's been another meeting here in 2005 with Dr. Janetta and Dr. McLaughlin put on a symposium. And then I saw Dr. Shulev in Boston about 3 years ago, and we were talking, and I said I'd like to come visit. So I came 3 years ago, and I came again last year, and I wanted to come this year. So last year we were talking, and I asked him what would be the greatest benefit if I could bring someone with me to teach or instruct, and he immediately said neurophysiology. We would really like to have somebody come and tell us more about how you do neurophysiology monitoring. So I started a foundation. It's very complicated in America how we use money for charity and foundation, and so I got some funding together to bring Dr. Sclavasi, and hopefully every year we can maybe do a different topic. So that's kind of how we started. Go ahead. Yuri came to Salt Lake January this year, and we went up to the Ski Mountain. This year in Salt Lake, we had one of the biggest snow years ever. We had 600 inches of snow. How much is that in meters? 50 feet. 50 feet of snow.
15 meters.
15 meters of snow in the mountains this year. And we drove up in a snowstorm to see the mountain. Go ahead. I work at two hospitals now. One is in Wyoming, the state of Wyoming, which is next to Utah. Wyoming Medical Center. Go ahead. And I work at Intermountain Medical Center in Salt Lake. This is Salt Lake City. Go ahead. And this is Pittsburgh, where Dr. Sclavasi and I work. Very big medical centers. So, what's really important as a neurosurgeon, and most of you are not neurosurgeons, or mostly neurophysiologists, neurologists?
50-50.
50-50. So as a neurosurgeon, it's very important to have a good examination. Dr. Sclavasi mentioned it as far as the physiologists go. But for us to get adequate data, so we know over time how we're doing, we need to know how the patient is before surgery, and how the patient is after surgery. I think this is very unique to neurology and neurosurgery. We were very focused on the physical examination. A lot of other specialties don't focus on it as much as we do because everything we do in such a small area can have very big consequences for the patient. And for us to know how we are doing and to improve, it's very important to have a base neurologic exam. And there's a couple questions that come up. Is this a patient who has expected benefit? If someone comes in with a spinal cord injury and they're complete, and is there a reason to monitor that patient? Or is there going to be a benefit to them neurologically? Is the benefit of surgery worth a new deficit? So there's some surgeries we do that we ask ourselves, if we go and do this tumor surgery, we're going to create a new problem. Is that worth the benefit of taking out the tumor? And then finally, the other reason the exam is helpful, I mentioned, is so that we can do studies and report our results and know where we can improve. So Dr. Skobasi also mentioned, and after leaving Pittsburgh, I have not yet had a hospital where the anesthesiologists were as interested as we were in waking the patient up. Everywhere I work now, it's very difficult to get our anesthesiologists to want these patients awake right away. They don't want a patient to wake up too early, because that's a problem, so they would rather have them wake up later. And as a neurosurgeon, it's very important that we assess the patient right away for certain surgeries, not every surgery, but some surgeries where we have problems, we're not sure, there's been some bleeding, there might be more bleeding. We want to know right away if there's a problem, so we like them awake right away. And so then you have to make a decision. If there's a new problem, is that expected? Do we expect, based on what we did and how the case went, is that normal for that patient to have some new problem, or is this really unexpected? And then you have to decide whether to get a new picture, imaging or not. So monitoring where it becomes useful is because we don't always have a really good exam right away, and we certainly don't have an exam during surgery unless you're doing an awake patient. The best we can do is have these markers of responses, electrical responses, to measure the pathways. I took a few notes here. We mentioned awake, doing somebody awake and testing. We can't really do awake spine surgery. They're face down. You can't wake them up. We used to, before we had such good monitoring, we used to leave patients awake with spinal cord injuries who had some function left. We would leave them awake while we turned them over and then put them to sleep because we were so worried about positioning of the neck. Now with monitoring, we can put them over, we can get an assessment before we move the patient. Before we even move them off the bed, we get our neurophysiologist to get a baseline, and then we flip them over and we can see if there's a change with their neck position. Sometimes even with x-ray, looks like your fracture's aligned, but we'll have delays in our SEPs or motors. And so and sometimes you can just move the head and you'll see them change. So it's a really wonderful tool for spinal fractures and spinal trauma, just in the positioning, just before you even do the surgery, to know that you've got them in the best position for their spinal cord. And then it allows us to do a neurologic assessment during surgery instead of waiting until the recovery room to see if there's a problem. Go ahead. So the benefits are that you get immediate feedback, and it's very important, I think, that you talk. I like to talk to the neurophysiologist in my room or the technician while I'm working, rather than waiting for them to say something to me. Because I don't hear anything from them. Usually they're okay. Usually they're good, but I don't know all my team members. I go to many hospitals, and I'm just not sure sometimes if they're really watching. So I always like to talk and say, especially when I'm doing something, and say, how are the responses? I think it's very helpful as a surgeon to initiate the conversation sometimes. And it gives you feedback right away. It also limits your costs. it limits ongoing costs. Once you invest in the equipment and you have the equipment, there's really, it just is a technician running the machine. There's not a lot of costs involved. It doesn't add a lot of cost to the surgery. I think most surgeries now, if I monitor versus not monitor, it might add 10 minutes to setting up the room. So they can put their little electrodes in and get things ready before we position the patient. So there's not a lot of expense other than the initial equipment. Once you have the equipment, it doesn't add a lot of cost to the surgery. And I believe the data shows that there's improved outcomes. Go ahead. There are some limitations to monitoring. And, you want high sensitivity. You want it to pick up every little problem, but you don't want it to be not specific. And I think this test, neuromonitoring, is highly sensitive. And I think it's not as specific sometimes as we'd like it to be. So in my experience as a surgeon, I will frequently get reports that things are changing. And I might alter how I'm working or take less retraction. And yet after surgery, even though the responses maybe don't come all the way back up, the patient's fine. So I don't think it's always very specific, but it is very sensitive. So you will see changes. I don't think you'll miss changes, but sometimes the changes aren't maybe as bad or what they seem at times. And that's where it becomes very important, and we'll talk about this as we go through more lectures, very important to know what anesthesia did. Did the new change, did it happen in response to something I did? Did it happen while I was chatting with my assistant? Did it happen related to anesthesia? Did the blood pressure drop? Is the patient's blood pressure lowered? Sometimes the changes aren't what we are doing, but there are other things happening in the room. And then they don't always correlate. When we have changes, I've had a couple cases, and we'll talk about this later too. There's different kinds of machines, and Dr. Slabasi mentioned alarms. So in America, where everything's driven by money, right, a lot of people are monitoring for financial reasons. So a lot of companies are making what I call dummy machines. These are all prepackaged machines that give you a green light and a red light, right? And a green light is everything's good, and a red light is there's a problem. There's nobody interpreting them. There's nobody looking at them. It just puts them together, runs them through a computer program, sets some alarm, and tells you. I've done a couple spine cases where I've had green light, everything was fine, and after surgery, the pedicle screw was in the nerve frame, and the patient's foot dropped foot. And I go back to the surgery and take the screw out, and the foot recovers, and I never had a change on the neurophysiologic monitoring. But those were what I call dummy machines. They were just boxes that interpret for you. And I think it's very important that you do this with somebody that can interpret them. Because I agree, there is no line, there's no absolute number with amplitude and delay that says this is a real problem, this is not a real problem. It's really very specific to each case. And so I've had a couple that didn't correlate. Two very obvious cases where the screw was pushing on the nerve. And, I think that was machine related, but I do think sometimes these can be oversensitive, and you need to understand that sometimes when you see changes, you just have to carry on, depending on the circumstance. Technical challenge. Back in the day when we were doing this, and I wasn't early, but just using the Bovie, using anything electric in the room, sometimes you don't even have to use a Bovie. Sometimes other electronics in the room would cause artifact in the recordings. I think you've worked a lot of that out now technically. You have filters and things, right? But sometimes you can have trouble with artifacts. Sometimes I'll do a trigeminal, and the technician can never get a really good baseline. For whatever reason, we're not getting good DSERs. And, sometimes it happens. It's not that often, but sometimes there's technical challenges. And I think keeping people educated and having certifications or training courses so they understand how we communicate and what we need to know, and so that our professionals can set their own alarms. Okay, so there's not just a number you look for, a 50% drop. But as you do more of these and you do more training, you'll understand what's an important change that you need to communicate. And I think it's important, personally as a surgeon, even if you see a change and you don't think it's significant, it might be. You know, when we do trigeminals, the number one source for hearing loss is just retracting on the cerebellum. And I would rather know very early, while you're getting a 10% drop in amplitude, that's not a problem if that's all I get. I'd rather know when it happens, because then I ease the retractor back, or I change the position, and then we don't get to 50%, or we don't get these millisecond delays because I make a change early on. So I don't like the idea of, I'm not going to say anything to the surgeon until it's 50%. I like to just know kind of as it's happening. And then there is some cost to get things started, but once you put the resources into training and equipment, you no longer really have many ongoing costs, especially if you reuse electrodes and sterilize them. In the United States, we have a lot of regulations on reusing certain items, but a lot of these things can be autoclaved and reused. We don't. We throw a lot of them out, but you can sterilize them. Next. This is a case I did recently of glossopharyngeal neuralgia. Had a very large pica coming off that went right between the 9th and the 10th nerve. Right between. And I didn't monitor anything in the throat. When I do trigeminal neuralgias, I typically only monitor BSERs because I'm just concerned about hearing. And I don't know if it would have changed this case, but this lady woke up with severe dysphagia, and she had a feeding tube in her nose for 3 months, and it all recovered. Her swallowing, her voice, everything came back. But I thought afterwards, that's the last time I'll do a glossopharyngeal case without monitoring, because maybe it was something I could have done better, that she would not have had to have the feeding tube for 3 months in her nose. But we do have techniques now that we can monitor the back of the throat and look at 9th and 10th nerve function. Go ahead. Go ahead. Can you click on that? It's like 3 minutes. Oh, sorry. Maybe we can't. Is it loading? Go back. You should go forward. That's a video. I was going to show this. Just give it a minute. I have like a 3-minute video.
Because
it's fine. It's fine. So this was a paper that Dr. McLaughlin, who came here first, myself, Dr. Janetta, and a few others wrote. Just an interesting point. If you've been following all the news in America lately about Trump, and so Chris Comey, you know this, right? So Chris Comey, if you hear about our FBI director that got fired, you guys follow the news? That's Chris's brother.
Really?
So I've met James. Did you meet James when he came? So Chris is very tall. Chris is like 6'6". I'm 6'4". His brother is 6'8". The FBI director is a really big man. Big man. Anyway, that's Chris's brother. He's the head of the FBI that just got fired, if you follow the news. So Dr. Janetta, at this time, which was in 1999, had done 4,400 procedures behind the ear for cranial nerve compression, glossopharyngeal, hemifacial spasm, and trigeminal. And what we found was the hearing loss rate dropped down to 0.8% from almost 2%. So we dropped our hearing loss rate. We compared before a certain time, like 1990 or 1988, and after, and we were trying to write a paper on how we improved our outcomes. This is why it's very important to do exams and documents so we can see how we do and report it. And the one factor that we thought was most important when talking to Dr. Janetta, and I don't know if we talked to you at the time, was between these two, we were monitoring everything. And prior to this, it was just, you guys were just starting, getting monitoring going. And so this, we believe, was all due to monitoring. The hearing loss rate from 2% to 0.8, not a large hearing loss rate, but we believe that's all from the monitoring, because the one thing we can do in trigeminal surgery is move your retractor. It happens all the time. The neurophysiologist says you're getting a delay in the hearing. You move your retractor, you wait a couple minutes, and it comes right back. Now, if you wait too long, it doesn't come right back, and that's why I like to know early. But it's really interesting how you can just see the response based on how much you're pulling on the eighth nerve. The eighth nerve goes into the petrous bone, and it's fixed. And it's the most sensitive nerve I found to retraction. So if you pull on the cerebellum to give yourself room to work, you might be pulling too hard on that nerve. And I think one of the biggest mistakes technically with this surgery, and you probably know this too, is putting your incision too far back. Then you have to really pull on the cerebellum. And doing this operation really is about putting the hole in the bone in just the right spot. That makes all the difference in every trigeminal or spasm case is where your incision is. And the reason it makes all the difference is because of this retraction issue. It's very sensitive to retraction. So this was a paper that I think really documented well the utility of monitoring. Go ahead. That's it. So as far as cranial cases go, you went through the outline. This, I think, if I can list them in some kind of order, I think this is most helpful for vascular procedures where you need to occlude a vessel and see if there's a change. For trigeminal, where just a change in the retractor. See, both of those kinds of things you can alter what you do. Spinal cord, when you flip a patient, you can alter the head position or the position of the fracture. Where it's harder to understand its value is things like tumor resection. Because no matter what you do, your goal is to take that tumor out. And sometimes this can be paralyzing. Sometimes you've probably seen it with surgeons. You give them a report that something's changed, and all of a sudden they don't want to finish the surgery. We had some professors, I won't name names, who would just do a little bit of work on a tumor or just do a little bit on AVM, and they'd see a change, and they just didn't want to finish the case. They're too risky, don't want to finish the case. And so there are some cases where monitoring can have almost an adverse effect if you're not prepared for it. If you're not prepared to press on when you need to press on and continue doing what you need to do. Spinal fractures need to be fixed. If someone's got a jumped facet dislocated neck and they've got some function left, you've got to fix them. So even if the monitoring is showing a big problem, you've still got to finish that surgery. And I think you have to be prepared sometimes to just go ahead and finish even if the monitoring has changed. But it has great, great utility, especially in procedures where you can change what you're going to do. Tumors, fractures, sometimes you just have to press on. But if you can change the position of the neck, change the position of your retractor, when you temporarily occlude for an aneurysm, if they don't have any changes, you might have 10 or 20 minutes. If they have changes, you might have 3 minutes, 6 minutes with the clip. So those are operations where you really can alter how you do the case and have a tremendous improvement in the patient. So that's just kind of an overview. Is there anything you want me to cover?